an operation gets extubated, and then we need to keep them extubated.
Yeah, what I meant to say, like non-invasive is a med.
Yeah, just to say what Sadiq is saying, now I think I'm very surprised that how can you manage without having non-invasive tools. That is very, very surprising, honestly. I will look at the unit, see what you have. The other thing I was
We manage poorly, that is how we do it.
No, I think it's limitation, because if you don't have tools, you can't build anything. You can't manage anything. Plus the Precidex thing is very costly, by the way. So we have adopted in Qatar a clonidine, which is 10 times cheaper, 10 times less costly. So I think that's something we should talk about.
एक चीज का फायदा ये गवर्नमेंट का अस्पताल है, यहाँ दवाई मिल रही है, no problem, cost हो गई है, इस्तेमाल
It should cost at the end. Even in Qatar they came after us because we used $1 million in 6 months in the cost. Anyway, so I guess finally my turn comes. These guys did excellent, esteemed interactive talks, which I'm very impressed. Great, really enjoyed myself as well. And again, I'm Jay Udasi. I'm one of the cardiologists and intensivists. I grew up partly in Karachi and Khan University, and then out to US and now back in Qatar. This is my third time in Lahore, a beautiful city. I want to visit tonight some spots, but last 2 times I came was almost 20 years ago probably. I do speak Urdu very well, and I also speak Sindhi very well. I heard there are people from Kambad, so I can interact with them in Sindhi. So, सवाल पूछ रहा हूँ तो बिल्कुल पूछो. So this is something. Now, Rizwan speaks Pashto very well, so if you have any Pashto speaking, he can explain to you in Pashto as well, and I'm sure you speak Pashto as well. Very good. So saying all this, my areas was more of a hemodynamic support, looking at the patient as a whole. So let's say you've taken care of the ventilator. Most of the time, we believe the cardiac patient's lungs are normal, supposedly normal. 90% of the time should be normal, so that should be the easiest part. And once you extubate, as we say, the intubator for cardiac problem, surgical problem, when surgery is done, you go ahead and extubate them and then handle the hemodynamics on their own and the problems. So without taking too much time, I'm going to go into this. So we're assuming that the patient is intubated, settled, came from OR, not having any major issues as such, and now we are looking at him as a cardiac point of view, what's happening. Okay? Let's see if this works. No, it doesn't work. Okay, so I don't have anything to disclose what I'm going to talk today. Yes, we have some other grants, but not on this talk, and no bias, of course, except the personal experience bias, which we all have. So font is a little bit small. I'm sorry if you can't see in the back. You can move forward. Some seats are empty. Objective today are that I'm going to look at some of the receptors, which I probably will skip some slides and not go in the depth of it, because that information is there on Google and everywhere else. But more important thing is to talk some basic concepts, how to manage these kids bedside, which we'll do again this afternoon. We'll talk about some of the cardiovascular basic physiology, and then some agents and their use in PICU, and discuss application of some cases if we can at the end. Okay, so as we said, yes, we're trying to cover things and give you some information and talk on the slides. Idea is not to finish the slides. Idea is to really convey the message and understand so that you can help the patient. So for me to stand here and finish my 100 slides doesn't help anybody. So yes, please talk, please ask, and be interactive, because that's more important to me. So yes, there are receptors in the heart, receptors in the body, which I want you to know only 2-3 receptors which are important for cardiovascular point of view. So alpha receptors, and then there are beta receptors. Alpha receptors, forget even subtypes of those alpha receptors, they are mainly on the vasculature. Beta receptors are on vasculature and on the heart. Mainly on the heart are beta receptors. And then beta receptors divide into beta 1 and beta 2. And alpha 1, alpha 2, I won't go in detail. Beta 2 are the receptors on the vasculature, and beta 1 are on the heart. There are no beta 2 on the heart, and there are not almost none beta 1 on the vasculature. So why I'm talking about this? Because medication effects are very important when you come down to looking at the effects. Okay, I think I'm going to skip this. I already talked about this. I think this is unnecessary now. I'll skip this. And we'll come to some other receptors in the body which increase the tone and some decrease the tone. By the way, I stole this slide from Ikram's last talk, so this is why I'm sharing this here. definitely acknowledge his efforts to make this slide. So you have these receptors which cause vasoconstriction and blood pressure rises. Okay, and there are receptors where blood pressure decreases and tone is decreased in the body. Without going further all in these details, which again is probably not practical for this session. By the way, I just want to know, how many are nurses here? Who's nurse here? Like a bedside nurse? And how many of you are ICU nurses? No, almost all. And how many are the doctors? Okay, very good. Thank you, thank you. Just to understand how I go through this. Okay, so starting curve of the heart, when the kid is coming from OR, this is important to understand that they go through bypass, they have effects. Important point is volume status of the patient and contractility of the patient. Those are the two things we really focus a lot. So yes, you don't want to give too much volume. You want to make sure that the volume is good, but at the same time contractility is good. And this is what we talk about when you give optimal length of the myosin actin, where you give a stretch of the end diastolic volume in the heart, which is stretching and having a capability to eject functionally. If you stretch too little or too much, that's going to cause problem. Simple as that. I'm going to leave it there. Okay, so afterload is equally important for the heart. Now Ikram will talk about cardiopulmonary interaction and how the afterload interacts with the ventilator, which is very important. So what we did today is talk about ventilators, I talk about hemodynamics, and then Ikram comes and finishes with putting two together as a cardiopulmonary interaction, how this goes about. So afterload is important, means that you have to pay attention not to the volume, but also what is the blood pressure, which is a simple bedside surrogate marker for the afterload. There are more to afterload, which is a stress, wall stress of the heart, but key thing is look at the blood pressure, what's happening. So volume, we talked about contractility, and we talked about now afterload, which is the systolic blood pressure. Okay, so the ways to improve cardiac output, sorry, I think went a little bit too far. Looks like I'm going forward. Yes. Here. So way to improve the cardiac output would be heart rate or stroke volume. This is your blood pressure and SVR, which is connected together. And then here's the volume, which is important. What is the volume? It's the stroke volume, and what is the industrial volume of the heart? And of course, this depends on the venous return. So this cycle we have to remind ourselves every time we look at these patients. Again, I'm leaving this superficially here because I have more to talk as the fundamentals and basic, which I'm going to just go further here. So, patient came from the OR. I'm not sure how you arrange receiving patient from the anesthesia team or the people who are coming to the bedside, which I did not include here. We have a set protocol. Dr. Seframon sitting here, where anesthesia team has the organized form to fill for us, the what happened in the OR, how the surgery went, how the system went. Patient arrives, they give us all the details from anesthesia point of view, then surgeon speaks from surgical point of view, and bedside nurse is listening, taking notes, fellows are listening, we are listening, standing there, so everybody has to be in that, taking the patient from OR to the ICU. So I think that's very, very important. I'm not sure how it happens here, but certainly, patient coming with the two nurses from the OR and then just coming to the ICU doesn't help at all because we don't know what happened before. So I can tell you in our medical world, which we have realized, communication, we don't talk to each other. We do things we don't tell each other, which really hurts the patient. So communication, telling each other, signing out details are very, very important. And I think in the cardiac world, as we all know, it's a teamwork, not that everybody else is a teamwork, but the cardiac more importantly, they're connected together from the prenatal care to NICU care to operation theater care and then post-operatively in the cardiac ICU or PICU care. So, common reasons we get called to the bedside. So I'm not sure how your sister works. I'm hearing that the nurses run the show by the bedside, which is great, but certainly you definitely need somebody to come and help out when things are not going right. So the common reasons I get called to the bedside for these cardiac patients, well, blood pressure is low. Or blood pressure is okay, but the perfusion is not looking good. Baby's looking grayish, pulses are not good, he's not warm, what's happening? So you get called. Heart rate is changing or rhythm looks off on the screen. That's the second most common reason. Bleeding, of course, coming from the OR, bleeding is the one thing need to be stopped, needs to be controlled, and that's something we'll talk tomorrow with the post-operative complications. No urine output is another problem which can happen within few hours of arrival from the from the OR to the ICU. You gotta mitigate that what's happening. Of course, oxygen saturations are dropping in some lesions, in some situations, or even you need to know where we are, what's the baseline, and how you're going to train this. Very, very important. And then, of course, acidosis and rising lactic acid on ABG. That is a late marker. When you have a high lactate and you have acidosis, we have lost the battle. Key is to avoid that. It's common nowadays that we pick these things way before acidosis happen. Because if you lose the battle, by the time acidosis is already there and high lactate is there. So this is the message I say, that don't rely on labs, rely on your patient. Look at him again and again and see what's happening. Okay? So, this is a 10-year-old who had Ross-Cono operation. Now, the other thing we really don't focus on, understanding the pathophysiology in lesions where what is happening with the patient, what do we expect. So Ross-Cono, I say it, fancy name. I impress people by saying Ross-Cono, but what does it mean? Right? This is the most important. Well, Dr. Ross described a surgery where if you have a bad aortic valve, you replace that with a normal pulmonary valve of the patient, and then in a pulmonary position you put a graft, could be a synthetic graft or homograft, means from animals we put. Okay, so that's the concept. Now we know that pulmonary valve in the aortic position, supposedly working okay, and then graft has own problems at the pulmonary position. So kid had a surgery on both sides of the heart, number one. Number two, Cono procedure is nothing but is resecting the muscle underneath the valve on the left side. Okay, so this kid comes here, anesthesia brought him, you took the sign out, team was there was a great information, numbers were great looking, anesthesia leaves, 10 minutes later, nurse is calling me, Dr. J, come on in, something's wrong. So let's see who will tell me. So again, when you have a screen, other thing we forget about is paying attention to every detail on the screen. Of course, we're in a hurry, we have 15 other patients standing there, us laying there in ICU. You come in the room, you got to pay attention to what's happening. And that has to happen in seconds. I'm not going to stand there and look at the heart rate and look at everything and take my, and this is experience again. So, somebody can tell me 112 heart rate, 10-year-old, and then you got to pay attention to the sinus rhythm or not. It's normal? Yes? No. How much heart rate you want on this patient? कितना होना चाहिए? 10 साल की बच्ची है, 10 महीने की नहीं है. Reasonable? Reasonable. Some people say post-operatively there could be 120, 130, but it's reasonable. I would say it's reasonable. Kid is intubated, let's say, and then she is comfortably sleeping. Okay. Blood pressure. Is this normal or abnormal? 78 or 45? What is a normal blood pressure for 10-year-old?
100.
It's okay.
That's 65. Map 65.
65 map, okay. So systolic is somewhere 90 plus, would you say?
Yes.
And then diastolic. So the way we calculate blood pressure, I give you simple math, which Ikram has worked hard on that. He published recently a paper looking at the old data from many years ago, and he has published that as reference in the PALS as well. Age, generally till 1 year old we say 70 systolic. After 1 year, you do twice the age plus 70 pressure. So if you're a 10-year-old, that's 20, twice the age plus 70 is 90. So I want to see 90 pressure minimum. So that's a low blood pressure for this child. Especially post-operatively, we know they have trouble, so you're going to pay attention to their blood pressure. Okay, so I come in the right away, I say it's a soft pressure, it's not perfect. She's sedated, intubated, maybe okay. Sometimes we deliberately lower the pressure because there's some issue in the OR, and which is important, again, communication from surgeon, that we need to know what happened actually, and I'll tell you about this patient in 2 seconds what had happened in the OR, which we learn later on. So, CVP. Now, you don't see a scale here, but CVP 2. Post-operative, 2 hours or 10 minutes or 30 minutes later, CVP2 is absolutely low, right? Normal CVP, which is the central venous pressure, which is in a way a right heart pressure, a right atrial pressure, or right RV end-diastolic pressure, they all should be same number, generally speaking, if the valves are open and no obstruction. So 2 is low, means normal venous pressure should run 5, 6, post-operatively should run 7, 8, 9, 10. Of course, too high is not good either. So you got two problems. Blood pressure is soft, CVP is low, saturations are 100, internal CO2 26, a little bit low. We are overventilating this child right away. You can know that because they have normal lungs, generally speaking. And then you have, she's breathing over, so maybe she's not that sedated. She's not that comfortable. It's still blood pressure is low. So first when I came in the room, I said, "Stop, she's sedated," but no, maybe she's not because she's still breathing at 49. Okay. Temperature, other temperature. This screen is not that complex, and I'll show you some other screens which are more complex. Before I go to those screens, this is the slide I created, which I think is a comprehensive slide, tells you quickly what is wrong hemodynamically. I'm not talking about, now, could be something wrong with the ventilator as well, but you have to go through these steps very quickly walking in the room. And I can tell you with the 20 years of doing this, or 25 years, I still think about these things when I walk in the room and go through this so I do not miss what's happening with the patient. So, what are the four categories? We say preload, afterload, contractility, and heart rate. People ignore this last part completely. My fellows, my residents, they ignore this. They don't look at the heart rate. Forget the rate, rhythm. They ignore the rhythm all the time. Now, if you're a trained cardiac intensivist and cardiac ICU working, you remember to look at it, of course. In a regular ICU, I see people miss a lot and don't focus on that too much, especially for cardiac patients. So, has to be a sinus rate and has to be an optimal heart rate. We have babies, neonates who come from the OR, they have a suppressed SA node. You have to pace them at 150, 160, 140, depending on the age and lesion. That's very important. The rate itself is important. There's something called Treppe effect. I'm not sure if you guys know what the Treppe effect is, or some of you may know. Treppe effect is the heart rate dependent contractility. So if your heart rate is low, your contractility, the ion channels, the way myosin-actin interaction happens, it's weaker. If you give the heart rate higher, now has to be a limited higher. If you go 200 or 170, I mean for newborn, that's going to be bad because now your filling is being affected. You can't fill the heart, right? You need time to diastole to fill the heart. Okay, so focus on heart rate. Of course, patients can have a problem with the sinus node, with AV node, and jet. We'll talk tomorrow, but we'll focus on these things more tomorrow. Okay, preload. So fresh post-op bleeding is very important. Okay. Let me tell you actually something here that I've heard multiple times. If surgeon has done a great job in the OR, I can guarantee you we can mess it up in ICU. Easy, we can mess it up. And we do most of the time. Respect to Salman here. If the surgeon has done a bad job, of course that's possible too. We cannot fix it. I can stand there and turn upside down. I cannot fix it. More often, surgeon does a good job, thank God, and we mess up. Let's just admit this. Okay? Smooth operation, smooth outcome. I can tell you there's not much to be done, generally speaking, if we're doing everything right. If we're not, then of course patient doesn't do well. So, focusing on the bleeding is simple. I think it's easy. Just use draining, bleeding, give products, fix it. We'll talk post-operative complications tomorrow a little bit, and I'll go into that. Tamponade, again, not that common. We had one tamponade in 5 months of cardiac surgery in Sidra, which Ikram was on call that night, and he picked it, relieved it, patient did well. Volume depleted, third spacing. Patients are leaky after bypass, so they may have they look puffy. First of all babies look puffy when they come from OR, most of them. Doesn't mean their volume loaded, oh my God. No, intravascular they may be depleted. So there's nothing in the vascular. So early on they require fluid bolus. I would say ignore your puffiness, ignore your edema, give as much fluid you need. Provided you're giving right amount and your thinking is right, that's the problem. But if you miss that problem, then of course you keep volume and you're going to hurt the patient. Then there are right heart surgeries where tetralogy patients, pulmonary truncus patients, they have a stiff right heart. And they require more volume as well regardless. I say as a rule to my team, post-operative patient, first 6 to 8 hours they require volume regardless and give it 5 per kilo, 5 per kilo. Now saline, 5% albumin, ringer lactate, whichever solution you have, give it. And you can always take it out. 99% of patients have normal kidney functions and they pee it out. Okay, we'll talk about Lasix's role in that. And then afterload is important. You gotta maintain your afterload of the left heart, which is systolic blood pressure. That's something we don't measure routinely, is the afterload for the right heart, which is the pulmonary hypertension, which is impossible to generally tell unless you have a PA line, which we are not putting any swan gaze anymore, which is a lot of complications. So think also at the same time, if everything else is good, maybe it's the high PVR, which is pulmonary vascular resistance. And then the contractility, all these are good. Okay, well then maybe what's the cardiac function? Maybe the blood pressure is low because of that. So you might need an echo for that. And again, you always have a baseline dysfunction in some of the heart conditions, so you have to accept that. Okay? So going through on each patient who has any subtle problem helps every single time I have done this exercise on every single patient. And 99.999% you rule out the problems, you fix it. And if you can't fix it, that's where I say, surgeon, my friend Salman, my friend Olivier in our program, what did you do? Help me more, what's happening here? And then you look for residual problems, residual shunts. Maybe the coronary artery was nicked. Maybe there was some other issue in the OR happened, which we need to know and try to fix it. Okay? Any questions on that? It's very basic, fundamental, no rocket science. Okay? Same patient now, as we said. So what are you going to do to this patient? We went through exercise, heart rate is good, clearly blood pressure is low. Why? Because your volume is low. Okay, is she bleeding? Look for no, not bleeding. Yes, volume low, because some patients act like this. You can give the volume. Of course, your ABG will come. Patient will be -10 best deficit, and pH may not be that acidotic. Lactate may not be high enough yet, thank God. But you gotta pick it early and give volume. And I can tell you the nursing, and this is something which people don't realize and don't empower. Nurses are the primary gatekeeper of the patient. If you guys do not initiate, nothing happens. Because I have 15 other patients a unit, I'm walking around, running around. How many you see these doctors who themselves every 5 minutes are coming to the room and looking for problems? No, because they may have other things, and some of them maybe just want to have a coffee or lazy period. Okay, but nurses, you call us, you put the foot down, get here, something's wrong, help me, or think, or intervene yourself. Again, I think nursing empowerment is lacking in our region, including Middle East, and we're trying to work on it to empower them to be that voice for the patient. So you give volume here, 5 per kilo, 10 per kilo, see if it comes up, blood pressure comes up. Don't walk away, as we always say, assess, reassess, come back, what's happening, repeat the gas. Okay. I'm going to now talk about a little bit of monitoring in the ICU, which I have to still see how your setup is here, but certainly, we are at the advancement where we have a lot of tools and this and that, but honestly using them is the key, and then getting the information and utilizing the information properly. So, look at this room. At this stage of my career, I walk in this room and I'm like, okay, what I'm going to look first? What's happening here? You have, forget the computer side, but this ventilator screen. Well, this patient's on ECMO, so you got an ECMO screen here, ECMO machine, you got a monitor here, and you got a near somewhere hidden behind here, which is a near infrared spectrometry. So I call this is a stock market. Wall Street. I'm not sure how many of you had an opportunity to go to stock market, even Karachi Exchange, and Lahore may have exchange, or forget the Wall Street I've been to, of course. New York Wall Street, it's just crazy. You walk in, it's just chaotic numbers. So what do you do with stocks? Somebody, if you play stocks, you look at the numbers, you disregard some, regard some. I call it selling the stocks and buying the stocks. In believing and making sense, what is the right way to do so this patient does better? Or your money increases if you buy right stocks. So same analogy, that you go in the room, you look at the numbers. So look at this patient, heart rate, blood pressure, CVP. Now I don't know how to screen, other presidents somewhere have LA line, of course. I'm sure you guys use LA pressures on some of the patients. So those number comes into play. And this is called, when you have LA line and CVP, and it's like a walking cath. Like great for me, I can interpret numbers and figure out what's happening, And this is the NIRS machine, which is near infrared spectroscopy, which gives you the oxygen content. It's not 100% reliable. You have to look at the trend. It's oxygen content of the brain. So this basically looks like a pulse oximetry, but right here, it penetrates in the brain and gives you somewhere oxygen content of capillaries in your frontal lobe. and just should correlate typically with the mixed venous oxygen saturations. Now that's a huge concept, mixed venous oxygen saturation. It's a basic concept which we'll talk at bedside, how important it is to do a venous gas from IJ line, typically from SVC blood, to see what the mixed venous number is so you can understand what's happening with the cardiac output. Okay, this number typically correlates with the mixed venous saturations. And that's a surrogate marker for me. And of course, its trend is more important. So I walk away for 4 hours to do some procedure, and I'm intubating somebody else and resuscitating somebody else, and walk back in, and I see what the curve was doing. So this curve was low here, and then going down like this. That's a problem. If curve had dipped down and nurse did not call anybody, that's a question. Why? We should have acted. Maybe it was a fluke, but still I want to come and check it. So again, you provoke, you call, you ask, we come in and figure out what's happening together with you. And I can tell you, I worked in US, Florida, about 10 years. Ikram was there, first few years of my life there. I can tell you, nurses have rescued patients and rescued doctors more than we have rescued patients and rescued nurses at the end of the day. And that's the empowerment we want to see in the program success. Okay, so let me go back here. So we talked about, we don't put PA catheters, so there's a heart rate, blood pressure, RAP, which is right atrial pressure, LAP, surrogate markers will be NEERs, renal NEER. We put also probe on the kidney, look at the oxygenation for kidney as well. And then you look at the temperature, urine output, mixed venous. Nowadays there are IJ catheters, they give you direct oximetry. They're not that commonly used. In fact, we are struggling in our unit to really correlate them and properly use them. And then there's, of course, ultrasound measurements, which are still a research tool. In fact, we were doing some research in Florida on those. They're common in adults, but not much in pediatrics. And of course, blood work and echocardiography is the late stage. Okay, when you find something on echo, or find something on the gas, the acidosis, we have lost, I would say, half the battle. And we missed something major in the patient, which we ignored. Could have been volume, could have been rhythm, could have been something else. Okay. This is the neonate after DTGA surgery, Jatine procedure, as we say. Dr. Jatine, I keep doing this again and again. So, heart rate 154 for newborn. Reasonable, normal.
Okay, yes.
And they run from 130 to 160. If they're below 120, my rule is to pace them regardless. Even if everything's hunky-dory, just pace them. Now you guys use, of course, your pressure wires, artificial, you have the people talk about that bedside. Tomorrow I have some talk on that as well. So how about the blood pressure? 54 or 37. Let's say mean is 30, mean is 40 here. And this is a 7-day-old baby, classic time when we do transposition surgery.
Low.
So I think it's okay, but you don't have a margin of error here. Okay? So I like to keep 60, I like to keep 45 or 50 map if I can. This patient, I didn't pull the whole screen, there's ALN line and the CVP is 12. So again, you also see the waveform a little bit, this is not very classic, but you'll see that the arterial waveform will go higher and lower. It'll be seesaw appearance, and that tells you volume is a problem. Though CVP is 12, which is reasonable for this baby, but again, need to watch, need to put an eye on this kid, what's happening. It may go wrong. I can tell you this patient half an hour later went to a jet of 220, and then we had to really do a lot of things. Jet junction ectopic tachycardia, which I'm not sure how much you have here, but roughly it happens 2-3 patients, 2-3% of patients. Okay, low cardiac output syndrome. I don't think we see it often. This was described a long time ago by Dr. Warnowski and CHOP, Children's Hospital Philadelphia, where we believe that, I say it may still happen, but 6 to 12 hours post-operatively after the bypass, all these babies have a low cardiac output, especially neonates. And that's where the milrinone came into play. And I'm assuming, I'm sure you guys can help me, all your patients, neonates especially, come on milrinone post-operatively. Some milrinone 0.5 micrograms per kilo per minute, yes? Yes. He's looking at the heads, yes. And this was implemented or guidelines after this study which Dr. Vilvanowski did back in 95 when he was at CHOP. So basically what you notice that at a 12-hour period you'll have the problem of the cardiac index dropping. And this is a study on mostly transposition babies he did back then. And some had a impact ventricular septum, and some had a deep thermia, and some had a low flow state. I'm not going to go into detail. The bottom line was these kids had a problem with the low cardiac output, and pressures were high, and then LAP was dropping. So basically, what are the reasons babies get low cardiac output? We list few of these reasons. You can have abnormal ventricular-vascular interaction. The bypass itself is a bad thing itself. It gives you exposure to a lot of cytokines, and these babies don't do well. You can have a functional univentricular circulation, which the single ventricles don't do generally well. They have an intrinsic cardiac dysfunction at low level. When they come back, they behave like a normal patient. Typically will have a lot more than the patients who are biventricular repair. Abnormalities of diastolic function after surgery to the right heart, which we talked about earlier. Those patients have a problem with the low cardiac output syndrome more in the residual anomaly, and this is something which of course can't help in the ICU, but need to figure out and guide our surgical teams to do something about it. So, talk a little bit more about ventricular vascular interaction. Again, ischemic peripheral vision injury is common, vasoconstriction is common after the bypass. And then again, you have what do we try to do to avoid this? People start using steroids to avoid the bypass effect. Center does it. We're adopting some selective patients right now. Not every patient. In Florida, almost every patient would get some steroids. Could be dexamethasone. Timing is not clear. How much to give? There's so much research areas which are not clear yet. We'll know hopefully the study going on now in CHOP. They'll probably guide us what's the right dose and what's the right time to give steroids before the surgery. And then post-bypass, we use the ultrafiltration, which I'm not sure if in the OR you guys do this here. Babies get ultrafiltration, muff? Depending on surgeon to surgeon practice. Surgeon to surgeon practice. Yeah, so I think this helps a lot to us. Honestly, patients come more dry side. They don't have much of those vasodilatory problems or vasoconstrictive problems, depending which stage you are in muff. Functional with the heart, we talked about this a little bit. I'm going to skip this. Diastolic function, I talked about the right heart problems. I'm going to skip that. And residual nodal lesions could be a different level, different many. So I'm going to skip that. Now, so when you have a kid coming from OR, things are not looking good. Something is wrong. You figure out quickly what's wrong. And I can tell you these are the 4 things you can help the patient with. Okay, generally speaking. So we have a bunch of medications we can give. Of course, volume being the biggest medication, believe it or not. Oxygen being the second biggest medication. Okay, those are medications. But then I'll talk about some other vasoactive and inotropic drugs. Ventricular and ventilator cardiopulmonary interaction. I can tell you that this is a very, very important topic to see what's ventilator doing to the heart. As I think Sadiq and Rizwan touched a little bit, but Ikram will be going after my talk, depending how we're going to do this. We started pretty late today, around 10 o'clock, so before lunch we're supposed to finish all these 3 sections, but we'll see if we can give today or tomorrow. So cardiopulmonary interaction is very, very important to manage and focus and see what's wrong where. And then the rhythm, as I said earlier, you have to focus on rhythm and fix the rhythm. Your problems will go away. Something, okay? And then you have, if nothing works, you go to ECMO, which is extracorporeal membrane oxygenation, or basically circulatory life support, which I've heard you have it. I'm not sure how robust, how often you guys use it, but certainly in last, our ECMO usage has been quite high. In Sidra, we've used almost 10. Well, post-operatively we put 4 or 5 patients so far. Other patients wait for other reasons. We've done like 10 ECMOs in the last, I would say, 3, 4, 5 months since July. And then, importantly, you have to really pay attention that when you use any medication that can affect your problems negatively in the right heart and the left heart. Same way the ventilator effects are. So there's a lot to think and a lot to really digest when you're planning and looking at interventions. Okay, so what drugs we have? When you're choosing a drug, of course you think about the PVR issues, which is the pulmonary vascular resistance. You need to think about what patients are prone to having a PVR high, which is the pulmonary hypertension, or high pressures in the lungs. Okay, we know that the kids who have a more circulated, pulmonary overcirculation, they do end up with some of the problems with the high lung pressure. So you got to watch them. And I heard you guys do not have a nitric oxide here, which again, if you tell me to run a unit without nitric oxide, I will refuse to take their job. Right now, I tell you, I'll refuse to work in that unit. It's so essential, so important, which I heard Ahmad didn't have it when I was there, and I know NIC doesn't have it. It's probably higher level issues. I don't know what's causing it, but I'm just giving my opinion, not knowing the background at all. So trust me, I have no conflict of interest in this at all. I just think that this is a very essential drug. Now again, good ICU care can avoid that. I can tell you, you can do other things which I'm sure you're managing, but nitric makes your life way easier, and I'm sure safe uses in the OR even before patient comes to it when we have patients who have a high risk. And then you have pulmonary venous hypertension. These are the kids who have a TAPVR, the obstruction, or the kids with the hypoplastic left heart syndrome. If you're doing Norwoods early on, they will have a restricted atrial septum, so the right heart is flooded. Sorry, the lungs are flooded with the backflow from the pulmonary veins, and these kids die very quickly if you don't operate right away and have a nitric and treat them properly. And then you have, of course, shunts, what you're doing in the PA brain has unstable PVR, and single ventricles, of course, have that. SVR is very important, means the system liver pressure, to think about what's happening to the child. Is there any obstruction? You don't want to use too much. Thinking those 2-3 things, you go, okay, what are the terms we use? I just want to give you this basic concept, which I'm sure you all know. I can probably skip the slide, but there are inotropes, which increase the contractility. There are vasopressors, which increase the SVR, means increase the blood pressure. And like again, one drug can have multiple actions. Okay, and I can also tell you, I use one drug for this purpose, I use other drug for other purpose that could be opposite actions, but I'm using for one purpose, and then I'll tell you how I use epinephrine and nitroprusside together. Oh, people say epinephrine, nitroprusside, oh, no, it's going to cause vasodilation, help my blood pressure. The epinephrine is going to help the heart by contracting it better at the end of the day. So then you have chronotropic agents, which is increasing heart rate. These drugs don't have a much role in the cardiac ICU, like a dopamine drug. Depending on the time, I'll go in some reasons why you don't want to use dopamine. And then there are drugs like a lusotropic effect, which is the diastole. Okay, so heart rate we talked about, very important. Imagine that the heart is beating 150 times in a neonate. Those 150 times, your calcium is being released from endoplasmic sarcoreticulum, going to the actin and myosin, binding to troponin C, causing the contraction, releasing back, going back to the sarcoplasmic reticulum. That happens 150 times a minute. Imagine what can not go wrong at every stage. So you need sometimes drugs to lusotrop, means relax the heart, means that diastolic period, the filling of the heart, means as important as the calcium is binding to the myocardium and causing contraction, equally important as the calcium releasing from there and causing relaxation, the heart can fill. So if you forget about that, I can tell you most of our patients have a diastolic dysfunction. Most after bypass. Yes, it improves in some and doesn't improve in others. So we have to pay attention, and milrinone does a very good job. There's a phospholambin pathway where activates it, and epinephrine does also a little bit of that, but milrinone does a lot and opens those reuptake of the calcium back into sarcoplasm, so it's not available for myosin and actin for contraction. So lusotropic drugs are very important, milrinone being the top notch. And then vasodilatory agents, we'll talk about those, and then ionodilatory against the milrinone. So saying all this, I'm going to go through these drugs very fast in interest of time, because this information is everywhere you can find, but I'll touch base some concepts. So epinephrine. Epinephrine used in a post-operative care is little, but I want my patients who are high risk to have epinephrine in the tubing when they come from the OR, which we follow that very well. High risk means there's an issue in the OR and contraction is a problem, the function didn't look good. You may not be on it, but if you're on it, you're on it. All you need is a 0.03, 0.04, 0.02 micrograms per kilo per minute. I want to mention this here, that epinephrine low dose has a primarily beta-2 effects and beta-1, so beta effects. So it gives you contractility of the heart and gives you vasodilation. Okay, that's what you probably need in the first few hours of post-operative period. Now there are kids who have a low blood pressure issue, then you have to use dose beyond 0.05 microgram per kilo per minute. Those effects are primarily some beta-1 receptor, causes contractility and causes now beta-2 effects are generally gone, are very little. So you don't get vasodilation if you cross epinephrine beyond 0.05 micrograms per kilo per minute. That's where there's a controversy nowadays in literature that when you are beyond 0.05 epinephrine, your gut vasculature is also vasoconstricted, so feeding becomes controversial, but now we can be a little liberal on that as well. So feed the kid a little bit, at least trophic feeds. But anyway, different topic. Epinephrine, very important drug, and I can tell you that's probably the only drug which I believe is also a CPR drug. You have to have it. In fact, we have a rule first 24 hours post-operatively in the cardiac ICU, high risk. In fact, almost every baby gets 2 doses of epinephrine drawn under the bedside. So we are quickly, and the volume is also drawn on the bedside, so we can quickly act on it. Okay, I'm going to leave that. Norepinephrine, I can tell you, I don't like it. I don't use it in cardiac ICU. You don't need it. Now, saying all this, there are some schools of thoughts. Some European centers use it for kids who have a vasodilation problem to cause vaso. But I'm telling you, epinephrine does the same thing. Why would you do norepinephrine instead of epinephrine? Because you don't want to afterload increase the baby and cause the heart to trouble, which is post-bypass surgery. So the first 24, 48 hours, I don't want epinephrine, generally speaking. There are 1 or 2 times we've used in ICU in Sidra. I can tell you I've used it in the last 10 years, maybe 1 or 2 times in cardiac ICU in US. So we don't use it. And I'm going to just say that much of isoprolol, which is isopril, which is a selective beta-1 agonist, causes increased heart rate, has no role in cardiac ICU except the children who have a problem with the SA node dysfunction. And those are the classic post-cardiac transplant, which we do in Florida, 25 transplants a year. So we use this a lot there. So I always have in my talk, but it kind of stimulates the. So when you heart transplant, the new heart comes into play, and there's no nerves, and that heart depends on circulating epinephrine. So what happens? A dual problem. You have SA node dysfunction, and then you have now no nerves, so we call it denervated heart. So we use isopril circulating to cause some beta-1 stimulation, so the heart rate remains for a week or 2. And then studies are now telling us 6 months later they get nerves build up and they do well. But isopril used only for first few weeks. In regular cardiac ICU, you don't use, generally speaking. And some myocarditis patients who have bradycardia, AV node dysfunction, RSA, we use isopril as well. So milrinone. I don't know what people were doing before milrinone in cardiac world, because since I've been in this world, we have milrinone, and I'm happy to have that. So again, a most important drug, which I told you the slides earlier. Dr. Bill Gornowski was the big guy who really taught us well about it. Every patient post-cardiac surgery, bypass surgery especially, post-bypass, should be on milrinone 0.5, 0.3, 0.75. You choose the number. In the OR, they also load when they're coming off the bypass. Load, I'm not sure here we load much in ICU. We used to load in some, not 50 dose, not 25, just 20, just to get them going. So milrinone is very important and helps you. And I can tell you, since that era and other improvements, we don't see the low cardiac output syndrome, which I just described to you earlier. It's very less and less and less. Okay? How does milrinone work? It's a synergistic to epinephrine. Epinephrine has a beta receptors I told you, and that increases the adenylyl cyclase and cyclic AMP and causes calcium influx and increased contractility. Milrinone is receptor independent, crosses the cell membrane and increases the cyclic AMP by inhibiting phosphodiesterase. So synergistic to epinephrine. So if you need epinephrine, of course you really should be on milrinone provided blood pressure is okay, which most kids do well. And blood pressure doesn't go down because you're increasing the contractility. So if your volume is tanked up enough, they maintain the blood pressure nicely. I'm going to skip that. Large volume distribution, half-life is from 6 hours to 8 hours and 24 hours. People wean slowly, you don't have to. Sometimes we just treat ourselves. 0.5, we go 0.3 and then turn off. You can turn off at 0.5 next day when the patient is doing well, after you're comfortable and everything is going well. Some babies require a long time, of course. I'm going to skip that. Levosimendan, not approved in America. We never used it. It's available, believe it or not, in Qatar, and I've used on one patient when all bets are off and we were really hitting the wall for 24, 48 hours. Maybe did okay, I'm not sure what levosimendan. What this does is calcium sensitizes. So this is a drug adult world is using quite a bit. It's a long half-life, 1 dose, small dose, and you give over infusion and then you stop and it works for the next 5 days. And classically sensitizes the calcium receptors and calcium effectivity. I don't have much experience on this, but people who use it rave about it. As I told you, I just used last time in Qatar on one patient, which I think effects were equivocal, so I'm not a big fan of this drug. Dobutamine, generally no role in cardiac ICU. I say this with cautious and respect for people who use it, but to me, there's no role in cardiac ICU. When you're really struggling and epi is too high and mirinone is too high, I'd rather put patient on ECMO than dobutamine. What does that tell you? Because, let me say a little bit, the butamine is a synthetic analog. It's not endogenously available, so it's made outside and has isomers. And I can tell you the effects when you mix the isomers in the outside in vitro and you draw the drug. You can have a more beta isomers or alpha isomers, and the effects will vary. So I have a variable effects. Now people have used it. I give you an example. I was in Florida almost 10 years ago. One of my junior faculty we hired, and the kid wasn't doing well. This was not a cardiac patient, but had a sepsis issue. And she kind of said, "Oh," I was signing out to her, "let's try dobutamine." And with half heart, wasn't a cardiac patient anyway, I said, "Use it." The patient got better. Okay, better means blood pressure got stabilized a little bit. Being on already, some other drugs. So yes, it has some role in specific kids, not generally in cardiac ICU. Vasopressin, again, afterload increasing the heart without epinephrine effects or without contractile effect, no role. I can tell you the only role I found in the past, in my experience, the kids who had lung transplant. So we did also lung transplants in Florida Center. So we had every lung transplant comes with a complete vasodilation. Heart is working. Lungs are of course new and they're adapting to the new environment. But the so some special cytokines are released with the lung transplant where they're very vasodilated. So we have to use vasopressin to get the blood pressure up. So those kids routinely get vasopressin. Generally, there's no rule. Dopamine, which is probably not Ikram's favorite either, not my favorite, not only cardiac ICU, but regular PICU and doesn't use much and shouldn't be used. And for the time, not sure how we're running, a few of the slides to cover, but I have 10 reasons not to use dopamine. This slide was built by, I think, mentor of our both, Dr. Zarsky. He was our chair at the University of Florida. And we also been adopting this and his concepts, and it's still true. And these are, so the reason is used, the top reason, there used to be a show, late night show that used to say top 10 things what happened yesterday. So we picked this top 10 reasons not to use dopamine. Again, say the least, there are some immunosuppression effects, there are some kidney effects, we call it a medullary dysoxia, and then there are some other variable pharmacokinetics with the low dose and high dose, D1 receptors, D2 receptors, how the whole splectic circulation works has a lot of problems. There's endocrine effects, the TSH gets inhibited, which is one thing I would actually mention here. Every cardiac ICU patient should get screening for thyroid functions and some also cortisol levels. But thyroid function is very essential. If you have a low thyroid, that kid will suffer regardless. Okay, that's an inotropic effect. More are we learning about thyroid hormone and the way in the body. Every kid should get it, and we make it almost routine to just check the endocrine. So one of the checklists at the end of the rounds when you're finishing ICU, we talk about what's endocrine problems. So people have this trigger business, talk about this. Okay, nitroprusside, very favorable and likable drug. And again, 3 drugs I mentioned to you, epinephrine, milrinone, nitroprusside. Give me these 3 drugs, but of course Lasix is no more a drug. Lasix is like a water we use in ICU, so of course you need that. You need some calcium and magnesium, but these 3 fundamental drugs are very important. I can run whole cardiac ICU, whole year, many years without any other drug, I can tell you. Okay, so this is the NO, donates the NO, so how it works is a nitric oxide, which is a vasodilator. So it's endogenously made, we're just copying. What are the drugs I described to you, by the way? Only dobutamine we also copied and remixed it. Everything else is already produced in the body, believe it or not. Whatever science has really explored or worked and discovered, it's all copying what God has already produced and made. We cannot understand the body fully, what's wrong and what is right, and how we can treat it. As you know, this genomic projects and figuring out what's happening. So this is, again, that's where I almost, how people say that we don't believe in God, some of are out there, but this is where I say you better believe in God, because we can't figure it out, So this again is endogenous, and we make outside, we give it, it's an NO donor that dilates through cyclic GMP, causes the vasodilation effects. Okay, when you are nitroprusside, classically you need small dose, 0.1, 0.2, 0.3, maximum I go 0.4 micrograms, okay? And short half-life, seconds to minute. You turn off, turn on, vasodilation, turn off, stops. Of course, it doesn't like the light, it has to be covered. You guys use nitroprusside here? Yes? Yes. routinely? Good. So that's good. But you need to have arterial line because blood pressure fluctuations are quite a bit because you can inevitably push it and you have problems. So I always have an A line when I use nitroprusside, 99% of the times. And other thing you want to watch is the methemoglobin, which surrogate marker is the ABG when you do. So you always have this column. So one thing, other important pearl here, when you order a test, look at each line the result comes back. How many of you look at the ABG and look at every line? Every line. How many of you look at a CBC every line? You do? Okay, say anesthesiologist, of course. Good one. So you gotta look at every line because that result is there for a reason. In methemoglobin, the way we see the ABG has a percentage. So 1% is good, 2% is bad. Crosses 2, you're in trouble. So generally everybody has 1%. So look at that number and when you go to ICU, ABG has that net, says methemoglobin, and you look at that number. So briefly, basically you get a cyanide poisoning as well, and the treatment is thiosulfate. That's the last step of clearance. Cyanide combines thiosulfate and it goes in the renal excretion. So you get a normal liver, normal kidney, some babies don't. I've used nitrite so much and back in the US, only 1 or 2 kids have to use thiosulfate drip. In adult world, when they use nitrite, they always put them on thiosulfate drip. Not many centers, but most of them do. In pediatrics, we generally don't because time period we use it only for a few days to a week or so. Okay. Skip that. Nitroglycerin is almost same as nitroprusside. People think, oh, nitroglycerin is a little bit better effect on coronaries. I don't think that's true generally practically because transposition surgeries post-op, they put them on nitroglycerin. We used to do that in Florida as well, but I think nitroprusside is equally good if you need it for regeneration effect. So at the end of the day, I don't see a big advantage. So you can live with nitroprusside without nitroglycerin. Other drug which has been more of experimental, not approved in US, it's a more people use for compassionate use. Long half-life, I'm not sure if you have it here. It's a vasodilator, not particularly great. Naseretide went away from, I used during fellowship and training and somehow went away. It's a drug which has the, and again, naseretide is what? We know it's a B-type natriuretic peptide, which is BNP, which comes from the stretched ventricles. Okay, so heart is not doing well. So if a heart failure, you already have a BNP in the body. So people say bleed from outside giving more doesn't help much. Have we used in 1 or 2 patients? Yes, but generally it doesn't. And there's some adult literature talking about the renal effects and renal failure where it kind of faded away. So nowadays it's not being used a lot in pediatric world or in adult world. Okay, so coming down to the medications, Milano running, every post-op, post-bypass run, baby will be on a Milano 0.5, at least in the tube being sodium nitroprusside. Now, I tell you, once you use a good muff, and babies mostly are not vasoconstricted, generally you don't have to have that essentially in line because you have time to get it if you need it. So we have kind of went away in our cardiac ICU Sidra not to have that routinely in the sense, but we have that already in the list and pharmacy knows that we can need it in the next 10 minutes, they'll provide us in 5 minutes. But good to have that around. Epinephrine, of course, in tubing if you need 0.03. Special situations, I told you isopril, nitroglycerin, some people use for transposition surgery, and nitric oxide, that's your pulmonary hypertension patients. I told you earlier, I talked about it, that in my view, it's a very essential drug to have. Other essential medications, every baby comes from post-op surgery, requires volume, as I mentioned earlier, not every, almost everyone. Babies typically, maybe older ones too. But remember, you're going to take the volume out. Look at third space, they get puffy by tomorrow morning or tonight. So watch the urine output. So here's the deal. Okay, so you had a great surgery, you came intubated, we looked at the ventilator. Rule number 1, patient arrives, sign out is done, all the labs. Detail LFT, CBC, ABG, VBG if you have venous line, which you do generally speaking, especially IJ line. And then you get a chest x-ray, you look at the rhythm, you make sure your pacer wires are nicely connected, test them already. Even if the kit doesn't require, we test and make sure it's working. Both sides, atrial and ventricular leads if you have both. So chest x-ray, you look at it. And then of course, babies requiring some fluid, maybe not, maybe yes, some don't require. By midnight, you're on less drip. As a rule. We use always almost drip on post-bypass. Some older kids, ASD repair, minor, they may not get it, maybe get a 1 oral dose by, Q8 or Q2, but less drip, 0.1 milligram per kilo per hour routine, go quickly to 0.2. And this 1 cc per kilo per hour unit output, first night, second night is not enough. You need to get them dry, more dry. Okay, most cardiac babies like to be dry and want to keep them dry. Of course, you're watching CVP, watching other things, but make sure you are. One thing I want to mention here, which I think is worthy of Nobel Prize winning, if somebody can figure out bedside and give me tools to figure out volume status of the baby, hardest thing to do. CVP trained, yes. Urine output, yes. Heart rate, yes. But it's very difficult. I can tell you there are kids who could be dry but maintaining these things, and then something happens and they go down like very fast. So volume status is very, very important to really think and make sure you keep track yourself. Computer gives you numbers, but I tell nurses really be vigilant about these and keep us updated on what's happening. So you can't just start 0.1 and walk away for the next 6 hours, or 0.2 and walk away. Monitor what's happening with the patient. I go 0.4 within the next 4 hours, or sometimes I give 1 per kilo bolus on top along with the drip so the baby's kidney can kick out. As I said, 99.9% kidney function should be normal, and it is normal, and they pee it out. Okay, I believe cardiac ICU patients are the more easier than the PICU. Right? The lungs are normal, the other organs are normal, and the heart surgery was done good. What else you to do in ICU? Just do simple, basic care. Things will go smooth. That's my belief. And then don't get into these terminologies. Calcium chloride, babies on epinephrine high dose require I maintain ionized calcium at 1.2 millimole per liter. Make sure unit is the same as you use, because in Europe and US there are different units. I try to maintain that. There's a little literature out now saying, oh, calcium is not good when you go too high. Guess what? It's okay because those small babies are already depleting from calcium. Their stores are not well developed. Sarcoplasmic reticulum is 50%. Another talk I give to my fellows, developmental heart, how heart is developing, and I can tell you those reticulums are so less. The receptors are less. The newborn heart is not that greatly developed yet. So first year of life, yes, and after first year they do well. And then magnesium is cofactor for calcium. So if you have low magnesium, calcium is not going to work. So make sure you maintain magnesium 1 millimole per liter, and that's equal to almost 2 milligram per deciliter. That's the unit conversion. So I just target 1 and give them boluses if I have to. Okay. 7-day-old post-transposition. I'm almost to the end. I promised somebody that I'll finish talking 1 hour. It's supposed to be 1.5 hours. I'm going a little fast, thinking everybody's hungry. At least I am. So, what's happening to this baby? Who's going to read me these numbers? Heart rate is? Tachycardia. Blood pressure? Soft, we talked about this. And I told you this is the same baby. CVP, this is the LA line. Okay. So what's happening here? Temperature is okay. This is a toe temp. This is a rectal temp, which is a bit low. So this is the talk I'm going to talk tomorrow. So the baby has most likely jet, junctional ectopic tachycardia, where you lose the AV association, atrioventricular association. Atrial kick is lost. Atrium is kicking on its own, and ventricle is on own, and typically they kick sometimes against the closed AV valve. That's where you have MA pressure rising here, means 10 here, but if you look at these spikes, it's going up to 15, 20, and that's called Cannon wave. Right? It's physiologic. So you walk in the room, nurse is calling you calling somebody, doctor, something's wrong. Of course, rhythm, afterload, preload, blood pressure, everything. You say, oh, it's a jet, rhythm pain. We'll fix it, things will get better. And we'll talk tomorrow how we'll treat the jet. Okay? I think I'm going to skip this completely because Ikram has this again slide made by Ikram, and I put this in the talk whenever I'm not followed by his talk, so I talk a little bit more about this. So since he's going to talk on, this is very important. How do you manage ventilator with the hemodynamics? Very, very important. And then pulmonary hypertension, I'll talk with the postoperative complications tomorrow. I'll mention today again, as part of the overall picture, do not forget that afterload area, which I mentioned in the differentials, where one of the afterload is the RV afterload, which is the pulmonary hypertension. And again, there are patients who have labile risk factors to cause pulmonary hypertension. And key is to really target your ventilation properly, avoid the agitational stress, and of course, when you're doing these intravenous suction, whatnot, you be very careful how often and how you do this so they don't get irritated. In nitric oxide, of course, I've said enough about it, so I'm not going to say more. But again, it's a vasodilator. It is localized, doesn't cause blood pressure drop, and you can give through ventilator. Nowadays, we give even non-invasive ventilation. We can give nitric oxide, which we have used in our unit in Sidra and in Florida. So works wonders for us. And again, it is must to say that you can get away by using it, and you can get by, but certainly be a difficult post-operative course in those cases. This is the line I was telling you. This is not a substitute for good basic intensive care, another cause of stability. Okay. In summary, past 2 decades, 20 years, last 20 years, really been advances in understanding of the physiology, and that's where we are focused for post-operative care outcomes. And I think we've done a reasonable job with that. And look at the cardiopulmonary system in its entirety when you're assessing a patient, not just heart. So I'm a cardiologist and I'm an intensivist. I did 2 fellowships. When I talk to cardiologists, they're like always telling me, talk about heart. No, talk about entirety. Because this is the key where you need to understand what's happening with the lungs, heart, and kidneys, brains, all connected together. But clearly the heart and lung is connected. So again, system and entirety is important. What is the most important thing? Common goal of optimizing oxygen delivery. This is the main thing, right? That's what I say. What is heart doing? Only pumping the blood. We pay so much attention. Lung is more important because oxygenating. It's exchanging your CO2 and oxygen. So lung, pay attention to lung as well, of course. But I can tell you, oxygen delivery is the key. So hemoglobin needs to be right, cardiac output needs to be right, and oxygenation in the lung needs to be right. Those are the key factors to deliver oxygen. And if you don't deliver that, that's what the ECMO concept is, that's what the VED support is. We deliver oxygen to the tissue and this. So I say the terminology intensive care. You have to anticipate. You have to go through the exercise, what possibly can go wrong with this child every single time patient comes. And what we do is after debrief happens, I go through with the team, these are the things can happen. Okay, and this is how you're going to act. From rhythm to cardiac to bleeding, to gas coming back in chest x-ray and tube location and line location and everything. When you look at the chest x-ray, don't quickly just look at the tube position or lungs. Look at everything. There's an NG, where's happening? Where's the other things going? So looking at the whole thing entirety will help you a lot managing these patients. So again, anticipate the problem and then act when it happens. I think I'll stop here. How's that? Where's the person who's challenging me? Can I finish in 1 hour? Okay, any questions? Hopefully it wasn't too much, too basic, I hope.
Any questions?
यार एक लेक्चर स्क्वीज कर लें जो दोनों में 2 ऑप्शन है कि लंच कर लें फिर लेक्चर कर लें फिर सेशन कर लें या एक काम कर लेक्चर कर